So welcome in, and let's go ahead and jump right into our next presentation. We're going to be exploring the heart valve surgery options, and Dr. Vinnie Bobot is going to be with us. He grew up in Mumbai, India, and he learned his passion for medicine at a very young age after taking his father to the cardiology clinic for heart failure. Yes, his education and training began at King Edward Memorial Hospital and the University of Bombay, where he earned a Bachelor of Medicine and Bachelor of Surgeon degree, followed by a Master of Surgery degree, and eventually a Master of Cardiothoracic Surgery degree. This guy has got it going on. He completed his fellowship of the Royal Colleges of Surgeons in Cardiothoracic Surgery at the Royal College of Surgeons in the United Kingdom. He also completed an internship, 3 residencies, and 2 fellowships at various institutions. That included the King Edward Memorial Hospital and the University of Mumbai, Toronto General Hospital in Canada, and as part of rotations at institutions in the United Kingdom, including Guy's and St. Thomas's Hospital NHS Foundation Trust, King's College Hospital NHS Foundation Trust, and the Royal County Sussex Hospital in Brighton. In addition to his clinical accomplishments, though, I do want to share with you that Dr. Bapat has been a collaborator among his peers in the world of transcatheter valves through the creation of 2 apps that are downloadable on mobile devices. So write this down: Valve in Valve, VIV, Mitral and VIV Aortic. Those apps allow physicians to access data and clinical insights to determine the technology options that are best based on the individual patient's needs. This includes guidance, insights, and implant procedure directions. So you'll have to check that out. And in the meantime, we're going to hear from the doctor again, exploring heart valve surgery options.
Thank you for this wonderful opportunity to share my thoughts on surgery for the heart valves. The aim of this talk is going to simplify some of the things, as there has been many advances over the last few years, mainly last decade. These are my disclosures. I work with majority of the heart valve companies, as my interest has always been in heart valve designs and novel solutions. I work with established industries as well as new startups who are coming up with new transcatheter options. There are 4 valves in the heart, 2 on the left side, aortic and mitral, and 2 on the right side, which is pulmonic and tricuspid. The 4 valves of the heart are intimately connected. Abnormality of the one valve can affect abnormality of the other valve. Left side abnormalities can lead to back pressure and leakage of the tricuspid valve, which is a very common problem. The function of the heart valve is very simple: unidirectional blood flow, but at the same time it has to be unobstructed as well. Hence, if the blood flow comes backward, which is called leakage, the valve is regurgitant, while if there is obstruction to the forward blood flow, it is stenotic. Both of these have implications. We are going to mainly focus on the aortic and mitral valve. Both these valves can either be obstructed or be leaking. Interestingly, the commonest pathology we see in Western world is obstructed or stenotic aortic valve and then leakage of the mitral valve. Of course, in developing world with rheumatic heart disease, mitral valve stenosis is more common. We are going to initially look at the aortic valve. Let's look at the main important thing which sometimes can cause confusion. Normally, the aortic valve has got 3 leaflets, hence it's called a tricuspid aortic valve. When it closes, it looks like a Mercedes-Benz sign. Some of us are born with 2 leaflets instead of 3, and hence when this valve opens, it opens in a more oval fashion or a fish mouth fashion rather than a circular fashion. Aortic valve is housed within the aorta, which is the main artery which emerges from the heart and supplies blood to the entire body. This aorta can become dilated, either secondary to the pathology of the aortic valve, such as aortic stenosis, or primary because of inherent elastic tissue deficiency. This deficiency can lead to stretching of the aorta, and the normal looking valve can start leaking because it's stretched and it cannot meet in the middle. Bicuspid valve is pretty unique, and we understand a lot about bicuspid valves than 1 decade ago. The blood flow in the bicuspid valve is more turbulent as the opening is oval. Because it's turbulent, it's less durable. Ascending aortic dilatations are also common, as bicuspid valve is associated with dilatation of aorta because of slight deficiency or weakness of the elastic tissue. Hence, we see patients at younger age, and when I say younger, it usually means 4th, 5th, and 6th decade. Unlike the tricuspid aortic valve, we usually see patients visiting us or coming to us in 7th or 8th decade. Also, there is higher chance that bicuspid valve patients will need ascending aortic replacement. Coming back to the commonest pathology, aortic stenosis, as you can very nicely see in here, aortic valve becomes calcified and hence it cannot open properly. It's a very gradual process. It's well tolerated over decades, and we suspect sometimes that it begins as early as 3rd decade or 4th decade of a patient's lifetime. However, we only intervene if there's shortness of breath, if the effort tolerance of the patient reduces. That means what you were doing easily a month ago or a few months ago, you can't do anymore. There's dizziness or blackouts, chest pain, and finally heart failure symptoms. Of course, it's also important that the valve is narrowed to a particular degree for us to intervene. But you may have a severe aortic stenosis, and we may say that we'll only do watchful waiting if you have no symptoms at all and your heart function and size is normal. Also, if your valve's not critically blocked and you are not symptomatic, we will observe you with serial echoes every 6 months rather than doing an intervention. Aortic regurgitation or leaking of the aortic valve is slightly uncommon. It can be because of the leaflet abnormalities itself. It can happen in tricuspid as well as bicuspid valve. It can happen because of infection of this valve, and this leads to either perforation or leaflet defects. And as I said earlier, it could be because of just the dilatation of the housing of the aortic valve, which is aorta, and hence when it is stretched, it starts leaking. When you are investigated for aortic valve, we may also find there are other issues such as coronary artery blockages, mitral valve pathology, tricuspid valve issues, as I mentioned earlier. And this is going to dictate what kind of treatment you're going to have and what approach of surgery or intervention you are suitable to. Hence, I would say aortic valve disease is a spectrum. You can have isolated aortic stenosis in presence of a 3-leaflet valve. You can have isolated aortic stenosis in presence of 2-leaflet valve. Aortic stenosis can be associated with the 3 things such as dilated aorta, coronary artery blockages, or other valves. Similarly, aortic regurgitation can also present with any of this. This will all dictate surgery. Now, surgery was the only option till I would say around 6-7 years ago. So let's discuss that first and we'll go back to TAVR later. Approach of surgery can be full sternotomy or less invasive approaches, also commonly known as minimally invasive or keyhole surgical approaches. Valve replacement can be done with a mechanical valve or biological valve. In aortic conditions, repair of the valve is only reserved for certain aortic leakage patients and not for stenosis. If it's a full sternotomy approach, it's the red line. It's actually the quickest and the easiest way to get to the heart. And despite the fact that it appears so large and more invasive, it heals pretty well. Usually patients are up and about by day 3, and by day 4 they have done stairs, and by day 5 or 6 they are ready for discharge. However, We also like to approach this through a keyhole or less invasive approach, which is orange, blue, and green line. This is conventional surgery. It's an extremely standardized technique. It's safe in most hands. It doesn't need any fancy equipment, and it's a very predictable operation. When do we recommend it today? If there are additional problems, as again I mentioned, if you have important blockages which need bypass, if you have important mitral or tricuspid valve disease or both which needs fixing, or if you have a dilated aorta which needs to be addressed, I think a full sternotomy is still the best approach. The last thing you want is to leave a problem behind. How we fix your heart well is going to determine how well you do and not the length of the scar. Sometimes it is safer to do it than less invasive approach such as infection of the aortic valve. Infections are notorious. They can be localized or they can spread to the surrounding structures of the heart, and hence the operation can become complicated. We like to perform these operations then through a full sternotomy. Similarly, if the anatomy is going to be challenging, we like to do the operation for your safety through full sternotomy. These are two of my patients. You can see the one on the left has got heavy sternotomy or a 6 centimeter incision in the middle of the chest, while on the right side you can see I have done the operation through the rib space. We usually keep this for isolated aortic valves only, and we use CT scans to determine which is the best way. There are other nuances as well, such as lung function, pain thresholds, etc. Going through the ribs is the least invasive, but ribs move and can be more painful. Experience for keyhole counts a lot. If it's a full sternotomy, the exposure is the best. With keyhole approaches, the exposure is small. So technical challenges are more. So if you are considering a keyhole operation, you should go to an expert who does it routinely. Transcatheter aortic valves. The first transcatheter aortic valve was done in 2002 in Paris. Following that, there were sequential trials starting from 2006, ending around 2014 to 2016. There are currently around 20 trials in this space to study advanced indications and limitations. This therapy is now approved in the United States for high risk, intermediate risk, and low risk patients for open heart surgery. Hence the question, if it is approved for all the indications, why do we do open surgery at all? So for that, we need to understand what TAVR is. TAVR is essentially a 3-leaflet valve inside a stent frame which is collapsed on a catheter. There are two types. One is the Edward Sapien balloon expandable valve, where we inflate the balloon to distend the device. And second is a Medtronic Evolute R valve, where it is hidden inside a catheter. And as it is exposed to the bloodstream at our body temperature, the stent expands automatically. Both the valves have done very well in clinical trials. Both the valves have very similar outcomes. There are certain nuances and anatomies where we choose one over other. At Abbott Northwestern, we use both these valves. So let's look at things where we would ask you that yes, you have aortic valve, you are low risk, but you need open heart surgery. Anatomical suitability is very important. All the trial patients were 3-leaflet valves because 3-leaflet valve opens circular. If you have a bicuspid valve and you are fit and well for surgery, we will probably err towards open heart surgery today because we can give you a better result, a durable result, and a bigger size valve. Nature of calcification can dictate the results after TAVR. If it's a evenly calcified valve, your results is going to be good. But if it is heavily calcified or there are more lumps and bumps, TAVR stent is not going to expand and seal everything, and you may have either incomplete expansion of the stent, or you may have leakages all around, and hence we may say you should have surgery for that. The third important risk which can be life-threatening is obstruction to the blood flow of the heart. As we don't remove your stenotic valve, we are just going to push these leaflets outside, and these can cause obstruction to the blood flow, and this is life-threatening. Similarly, the nodules of calcium can injure your aorta, causing perforation and bleeding. So how do we assess? These are some of the examples where these are some of the examples where the TAVR didn't work very well. You can see there is extreme calcification, and hence there was a lot of leakage. In this particular patient, we knew that if we do TAVR, it's going to injure the aorta. This gentleman was 91 years old. Hence, I proceeded with a keyhole operation to do his surgery. This patient was 75. He had bicuspid aortic valve, and as you can see, it was heavily calcified. So we knew that that stent's not going to expand very well. Hence, we did open surgery. This patient had a TAVR a few years ago, but his aorta kept dilating, and now it's more than 6 centimeters, and hence underwent open heart surgery with replacement of the aorta as well as the valve. All these things we can now look at the CAT scan, which is specially performed as Ecg Gated Cat Scan. That means this is the CAT scan which is synchronized with your heartbeat to eliminate any movement. And when we do 3D reconstructions and modeling to understand which TAVR will work well with you, or if TAVR is not going to work well with you. Hence, the ideal patient which we identify on the CAT scan as an example shown here would be someone who has got a 3-leaflet valve which is evenly calcified, and the patient's femoral arteries or the groin vessels are easy for access. And the poster child for this is no one else but Sir Mick Jagger. He had a TAVR around a year and a half ago in New York, and you can see him practicing for his gig 6 weeks later. He could only have this because he has an ideal anatomy for TAVR. Coming to valve choice, and let's not forget that TAVR is also a biological valve, is we conventionally divide them into two, a mechanical and a biological valve. In 1966, Dr. Harkane, who is one of the most famous cardiac surgeons in the world, defined 10 commandments for an ideal heart valve. The two important commandments are number 3, which is non-thrombogenic. That means a valve which doesn't need anticoagulation or blood thinners. And number 10, which lasts for lifetime. Now, unfortunately, this just doesn't exist. So this is the first mechanical valve, which is ball and cage valve. It's one of my patients. You can see it has worked very well in this particular patient for more than 4 decades. New designs came through, and the one which is now commonly used is the Bi-Leaflet Valve, which was invented in the city of Minneapolis by Professor Kirkland and his team. The upside of this is it can last lifelong. The Bi-Leaflet valves which currently use pyrrolite carbon can go on for 100 years. But the downside is it needs anticoagulation. So when do we recommend them? Younger patients and patients who have no contraindication for blood thinners such as bleeding ulcers, kidney stones, nasal bleeding, patients whose jobs are mechanics or in heavy industry where cuts and bruises are common, could be a chef, or patients who don't want this for lifestyle, patients who want to do skiing with their kids, or patients who want to do contact sports. The matter of fact is, in younger patients, if we use biological valve, it lasts less. However, mechanical valve also has its problems. Biological valves are also known as tissue valves, or pig valves, or cow valves. The good thing is no anticoagulation, but the downside is they are certainly going to degenerate. We just don't know the span, but commonly in a patient who is 70 years old, they should last for 12 to 20 years in the aortic position and 8 to 15 years in the mitral position. If you are younger, they're going to last less, and in mitral, they always last less than aortic. So when do we recommend them? In older patients, of course, and in patients who want to say plan family when they're young, or occupation and other aspects which we discussed. But now most people want it because they have a promise of valve in valve. So let's look at what is valve in a valve. Wouldn't it be amazing with TAVR technology which has become mature if we can just treat abnormal tissue valve with a TAVR device? So a patient will have no anticoagulation for 25 years. So let's take an example of a valve on the left side which is surgical valve, and if it doesn't work very well, we put a TAVR device inside it. This is my patient in 2010. We did a transcatheter aortic valve. This was his third operation. This was a quick procedure, no blood loss, and he was playing soccer with his kids in the second week. Amazing result. So why don't we do it in everyone? There are three main issues. The first issue is the Russian doll effect. We are putting a valve inside another valve, so the new valve is going to be smaller. If it is smaller, it's not going to last that long. That means this is going to have again a further limited lifespan. If you are in late 80s, early 90s, maybe this is acceptable, but if you are younger, it probably is not. Coronary obstruction is a very well-known complication. It happens in around 1 to 3% of patients. Usually we can now calculate by CT scan and give you an advice on whether you are at risk or not. But at times, if this happens despite our best results, this can be life-threatening and we'll need an emergency operation. And more importantly is durability. For example, this is a case with a very small surgical valve, size 19, and then a size 23 valve put inside. So it has not expanded fully. This lasted for 9 months only. I had to do a redo operation to explant both the valves and do open heart implantation of a bigger surgical valve under vision. So the solution for this may be smart surgery. Let's prepare and perform surgery in preparation for TAVR. What I mean by that is implant a larger valve. Make sure we implant a valve which has got the best track record for durability. Also choose a valve, the newer designs where the base of it can expand to eliminate the Russian doll effect. So these are the things which we are applying now in our practice. Same thing will apply on the mitral side as well. So let's move on to mitral valve. As I mentioned earlier, mitral valve can again be stenotic, that means obstructed, or leaking, that means regurgitant. Leakage is the most common. As you can see very beautifully here, blood is going back into the left atrium backwards, and then that leads to lung congestion and other side effects. Surgery for the leaking mitral valve, we tend to repair these valves when possible. Mitral valve is like a parachute and it lends itself for a repair. If we can't repair for whatever reason, then we replace it. Both these operations can be done through a traditional approach or a keyhole approach, depending upon the complexity, which determines the safety and outcome. And finally, if patients are high risk for this, we have transcatheter options, which are commonly known as clips. Let's see an example of a mitral valve repair. This is the patient who had a repair, and you can see there's a ring which is maintaining the integrity of the heart valve. It's better for the heart, better for the patient. This can be done, as I said earlier, through a keyhole approach, and if it's complex, it should be done through full sternotomy. If it's replacement, it's the same two options again. However, there are some differences. The durability of the tissue valves is less in the mitral position. That means if we are going to implant it in a 65-year-old, this patient is going to need another operation or intervention soon before he reaches 75. Mechanical valves hence are preferred, especially if you are already in atrial fibrillation and you are on blood thinners. There are now new trials at present going on to try the new blood thinners, also known as NOACs, but at present the only reliable anticoagulation is with warfarin. Anticoagulation in the mitral is very critical. Mitral valve is less forgiving than aortic and doesn't tolerate fluctuations that well. For high-risk patients, there are catheter options. MitraClip is an approved option now, and we are one of the centers which are leading in this technology. Hence, if we come back to you and say you are not suitable for this, it must be for a good reason. MitraClip works on the principle of clipping both the leaflets together in the center. It can sometimes induce obstruction, and hence we have to be very careful to select the right patients. There are other emerging options such as transcatheter mitral valve replacement like TAVR, and again at Abbott we lead this technology. And there are some new annuloplasty devices, all currently under FDA approved trials. Similar to the aortic valve, we can do mitral valve in valve and mitral valve in ring. This is a pretty challenging space at present. This is an example of a very early patient where a mitral valve in valve was done. The result looked quite nice. However, 3 minutes later, the valve embolized. This happens because the closing pressures are very high. Similarly, mitral valve in ring, there are multiple types of rings and all rings are not suitable. This ring in the next example was suitable. Valve in valve labs were created by me and my team, and they provide guidance to all the patients. These apps are free, they are downloaded in 130 countries, and they are used by most people in the TAVR field. They guide the operators in choosing the right patients for valve in valve and valve in ring. Hence, currently we are at a threshold of a changing paradigm. Lifetime management of a patient is important. Aim is, can the patient only have one open heart surgery or no open heart surgery? But more importantly, no anticoagulation either. Lifetime management can be confusing. It mainly depends on age, durability of the valves, and life expectancy. As you know, the life expectancy is on rise. So definition of young and old few years ago or a decade ago may not apply today. But the valves are lasting longer as well. So there is a lot of complicated algorithms we have to use when advising a patient what to do. What is young for valve replacement? I am always asked this question because the age is a very important determinant of mechanical or biological. This is one of the definitions used in the guidelines, but my definition is different. I feel patient is young if patient is going to last longer than the biological valve, and patient is old if the valve is going to live longer than the patient. That means here TAVR makes sense really. Let's take an example of a patient who is 60 to 65 years. If I do a TAVR now, he is going to definitely need a TAVR in TAVR or an open heart surgery at age of anything between 70 to 80 years of age. That means patient is much older by then. But if I do a surgical valve replacement, he's going to need a valve in valve when he's in his late 70s and 80s. So maybe surgery in this patient is a better option at present, at least from our current knowledge. If we still use TAVR, you can see on the top, patient will have at least 3 interventions. 3 interventions have 3 unknown issues, additional complications. And there's a very high chance that TAVR in TAVR, you're going to be on blood thinners. So we need to understand this field a bit more. If patient, however, is older and as the durability of TAVR becomes clear, patient can actually have TAVR now and then have either TAVR in TAVR at the age of 80 or if needed surgery. But if you are fit for surgery and you think your life expectancy is going to be good, maybe you should just have a surgical valve at present and then have a valve in valve when you're much older. So again, as I mentioned earlier, these are quite complicated algorithms which are simply evolving with evidence. Coming back to my patient, this is a patient which just demonstrates how responsible use of technology benefits patients. He has had this ball and cage for more than 4 decades and now in 2020 he has a TAVR device. At Abbott Northwestern, our valve team caters to this concept. We see the patient together. That means we surgeon and a cardiologist sees the patient. We discuss this with all the advanced imaging specialists. We have a healthy debate and we have confidence. That's why in applying new technology. All our patients hence gets all possible treatments, at least consideration for it under one umbrella. These are the strategies of aortic valve. From 2000, we have now moved to 2013. We have multiple options. Same thing applies for the mitral valve. We have again multiple options for this. The English phrase comes in my mind, horses for courses. We have different options for different patients, different options for different valves. Thank you very much for this opportunity.